Good afternoon, everyone. Certainly, by choice, I wouldn't present after Professor Zain Karrar. It will be like serving a meal after dessert. This is a very important topic, and I certainly wouldn't miss the opportunity of health policy makers being around here without putting some light on this very important, vital issue of maternal mortality. This is a very quick look at the introduction to look at the Sudan. This is a map following the separation of the South. The country has a population of almost 34 million. It's still the third largest country in Africa and the 16th largest country in the world with extreme diversity. Sudan has almost 600 tribes and speaks almost 400 different languages and dialects. The WHO has defined maternal mortality as death of a woman while pregnant or within 42 days of the end of her pregnancy by causes either directly or indirectly related to childbirth. Now, the states of the world have gathered at the famous Millennium Summit in the year 2000, and they have made timely goals. The fifth goal was to reduce maternal mortality by 75% by the year 2015. I don't see this happening in the next 3 years, certainly not for Sudan. However, the good thing about this was this issue was never so prominent in the international agenda before that time. The reasons are known. In addition to the international economic crisis the whole world is going through, Sudan has recently lost 75% of its oil reserve. That was the major source of income to the country. The country is highly indebted, which has a direct implication on the growth agenda, the poverty reduction, and realizing the Millennium Development Goals. Today, as we speak, half of the population would be rated as poor. Now, Sudan is the 11th country in terms of maternal mortality rates. Sudan and 10 other countries will have 2/3 of the maternal mortality rates of the whole world. I think this is probably even underestimated because of problems with the birth and death registry. I think the numbers might be a little bit underestimated. The sad news is most of these deaths are highly preventable. These are the actual figures that has been presented by many reliable sources. The maternal mortality rate for the year 2006-2010 was reported as 1,107 per 100,000 live births. The adjusted ratio for 2008 was 750, and the lifetime risk of maternal death for a Sudanese woman was 1 in 32. I'm not going to compare this to the lifetime risk of maternal mortality for a woman in the developing countries of 1 in 8,000. But if we do compare this to neighboring countries like Libya and Egypt, the rate will be in the range of 1 in 400. And the figures are rising. If you compare 1990 to the year 2010, the maternal mortality in Sudan has almost doubled. And even what is worse is for every single woman that dies, 30 more women will stay disabled. They will suffer either long-lasting injury or disability. It's not a secret that we have one of the highest incidences of obstetric fistula in the world. We see almost 5,000 new cases of obstetric fistula in Sudan. These are the figures by state, and it's obvious that states that suffer instability and displacement, states who have highest rates of refugee camps, have the highest mortality rates. And these are the maternity statistics for the years 2006. 50% of the women almost had a delivery at home, attended by a skilled birth attendant, and less than 20% of the women delivered in the hospital. Contraceptive use is almost non-existent. It's 8% of the population in a country with a high fertility rate. Now, I have selected two quick examples in two largely populated cities in Sudan, which were Kassala and Wad Madani. And I looked quickly at the figures of those. In Wad Madani, there was a retrospective study, a 14 years study from 1985 to 1999. They looked at a large number of women, and the rate that came out was almost 2,000. The main causes of death were sepsis, malaria, hemorrhage, and hypertensive disorders. Interestingly, 2/3 of the in-hospital maternal deaths followed cesarean sections. 2/3 of the women who died were coming from rural areas. The figures for the Kassala state were not very different. The direct causes of death included obstetric hemorrhage, obstructed labor, and puerperal sepsis. The indirect causes were anemia and acute febrile illness, largely malaria. But what was striking here was that almost 75% of cases, there was some delay of the referral to the woman to the hospital. Although there was a high recognition rate that there was a problem, but there seemed to be an obstacle to refer the woman to the hospital. So most of the deaths did happen at home, and there were transportation problems for more than half of the women. These three delays were recognized as the three major contributors to maternal mortality in Sudan. Delay in seeking appropriate medical help for an obstetric emergency, whether it was recognized or not, whether it was because of cost or something else. Delay in reaching the appropriate facility because it's not nearby, it's quite distant, or because of lack of roads or lack of a vehicle to transport the woman. Then delay in receiving adequate care even after reaching the health facility, which I believe is disastrous, because once a woman reached the health facility, her chances of survival should be better. However, because of shortages in staff, supplies, power, or water, the mortality rate was quite high. These are the contributing factors. Prolonged war, and you have seen the figures for Darfur. The displaced women had a very high mortality rate. Cultural malpractices, and here comes the famous female genital mutilation that's still widely being practiced in rural areas of Sudan, as well as early pregnancy. Poverty, low income, malnutrition goes without saying. Lack of education, 62% of the women who died did not know how to read or write. There was a lack of transportation, lack of maternal health services, and lack of trained staff. So in conclusion, the maternal mortality rate in Sudan is still unacceptably high. The main direct causes of death were sepsis, hemorrhage, eclampsia, obstructed labor, and prolonged labor. And the indirect causes were mainly malaria and anemia. The most disadvantaged populations were the rural populations. And surgical interventions like cesarean section contributed highly to the in-hospital deaths. The proposed solutions, I believe, campaigning to raise public awareness that there is a problem and to stimulate governmental action, and improving provision of emergency obstetric care in all health facilities, as well as improving family planning care, and improving the coverage and quality of skilled birth attendants in rural areas. These skilled birth attendants are the first line soldiers in this battle. Unfortunately, there is a question whether these skilled birth attendants are actually really skilled. There was a huge multi-center study that was done in Benin, Ecuador, Jamaica, and Rwanda. And the outcome of that study that these women were largely illiterate. They have gained their talents through experience, trial and error. There was no form of real formal training. And most of these women were not of the governmental payroll. They were paid fee for service. They were unable to answer simple questions on management of third stage of labor, management of postpartum hemorrhage, management of a retained placenta, and they were not able to identify pictures. So the WHO has an integrated management of pregnancy and childbirth as a competency standard. The question is how to get these women motivated. The doctors is another big issue. I'm not going to talk about that. My colleagues have done already. However, we know that the number of medical schools in Sudan has gone from almost 3 to almost 30. So we are graduating more and more number of doctors. The Royal College of Obstetricians and Gynecologists have a very successful center in Khartoum. There are almost 150 new candidates who pass the first part every year. However, these people disappear. They have no impact on the maternal mortality whatsoever. It seems that we graduate to export. So the issue of migration has been discussed extensively. I'm not going to touch on that. However, there is a very important example that I just want to set. This is a group of committed people in Omdurman Maternity Hospital, which is the busiest maternity hospital in Sudan, with 25,000 deliveries every year, and a group in Cork University Hospitals. So this group of people took the Award of African Initiative, which is an Irish healthcare award made specifically to upgrade health system to reduce maternal and prenatal mortality. This was a 7-year partnership, a very active partnership, and at the end of the 7 years, these people managed to reduce maternal mortality in maternity hospital in Omdurman by 86%. And the stillbirth rate dropped down by 50%. These are figures that we need to stop and look at. What exactly did these people do? What happened is that there was groups of multidisciplinary teams that made continuous visits to Khartoum, delivering management, emergency, and other training sessions. And they have taken other measures on areas like waste management and infection control and all that. So the project aimed to implement evidence-based and efficient obstetrics and gynecology. And the results were very, very impressive. And they were given the Excellence in Healthcare Management Award. So in conclusion, we should admit that there is a problem, an unacceptably high maternal mortality rate in Sudan. Women's lives are worth saving. They have the right to enjoy a safe motherhood like in other places of the world. However, effective policies and legislations to reduce the maternal mortality has to be implemented, with tools for advocacy and accountability. Collaboration, like the example of the maternity hospital, has proven in the past to be very effective. So such collaborations should be actively encouraged. Thank you.